Well, and I add my thanks for being included here. And unfortunately, I do have a big mouth, so you've heard a lot, some of the comments, but I do have some other things. And like Sharon and like Laura just said, I actually changed the name of the workshop and my presentation because I refused to use that word. And so I'll explain that a little bit in my slides. But we're talking about human research and really how it is time to hit the reset button here and move forward. Okay, and I'm usually really good with this, but if I'm hitting the right arrow, is that right? Okay, there, finally, okay, third time. So if we stop, what you're gonna hear from me is more of taking a step back and a generalization, which will cover some of the points of what has probably prompted Sharon in putting together a terrific model. And so you've already seen a case study or an actual project in mind. Here's some of the thought behind this from a patient viewpoint, from a patient advocate viewpoint of someone who's worked in cancer research now for over 20 years. And I'm really both impressed and frustrated with this meeting because we've been talking about this stuff since I got involved over 20 years ago. And we need to stop talking about this so we can move on to some of the more important problems. So I'm hoping that we can actually see action taken from this workshop. So, you see a Marcus Welby kind of guy here, for those of you that are old enough to remember Marcus Welby. And we have the Belmont Report, and we have Helsinki, and we have all of these different things that we talk about, research protections and why we have them and why they're involved. But so in the 20 years that we've been talking, or over 20 years that we've been talking about this, what's happened? Well, Google's conquered the world, and they've already gotten into and decided to get out of the healthcare market. There's a reason for that. And those are some things that we need to be thinking about. We now have mobile tools. How many of you do not have a smartphone with you today? Okay. And how many of you don't know that mobile phones and cell phone usage is higher in some underdeveloped countries than it is in our country? Okay. That's the world that we live in today. They're jettisoning above us in a lot of the antiquated systems that we have in this country because they're able to get in now in 2014 with new technology that we can't figure out how to insert into our system. So these are the kinds of things. Meanwhile, cancer has become more complicated. We've heard about that today in many different ways. And then the common rule. So how does the common rule fit into all of this? Have you actually Googled it? I did. So I Googled the common rule, and it doesn't come up with a lot of stuff. And what it does come up with first is the OHRP definition of the common rule. And so I did a readability test on this, and it's at a 12th grade level, which is actually better than I thought it would be. But it's at 60% passive sentences, which is not good. You want that low. And it's at a 22% reading ease, and that's not good because you want that really high. Okay. So this is what the public sees when they even start to hear about these kinds of concepts and might want to go ahead and say, common rule, what the heck is that? Oh, well, let me Google it. This is what they see. This doesn't tell them anything. It doesn't help the cause. It doesn't help this field. It doesn't help cancer research or any type of medical research. We've got to get a better handle on this stuff. How many, okay, we have some problems between Macs and other stuff, but how many informed consent redos have we had? I don't know, but I've been involved in at least 5 of them through the years, and on a national level. And we're still not getting to what the real issues are. Regulations, many interpretations. One thing we haven't talked about, we've talked about IRBs, but we haven't talked about how many of them are there. And how many committees within an institution are there of IRB committees? What type of interpretations and problems do we have with all of that? So the reality is, if we look at informed consent, and we want to call it what it really is, it's a risk contract. That's what it has become. That may not have been what the original intent was, but even nature admits that, okay? So whose risk is it that we're protecting? And why The way a lot of these are written is the institutions are looking at patients as liabilities. And yet we want them to enroll in these studies because it's a whiz-bang thing and it's wonderful to do. So you see the kind of mixed messages that people get from the way that we present research to them. And the result is, and you might not be able to see the red there, but cover your aspirations for an acronym that we all know and love, is really what is the result of all of this. Okay, now also notice this picture. I thought this was great. When I tried to find pictures for informed consent, there's hardly anything. And then we get this one with a person who's signing a consent, an informed consent, because this is what was Googled, in the hospital bed with the name badge on. That's what I meant this morning when I said, to patients, consent doesn't mean what it means in these discussions. Okay, it means, oh, I want a medical procedure, I have to sign this form. Okay, now we get to this word. Okay, what the heck is this word doing in the language if we actually want people engaged in clinical research? What does subject mean? Well, if you look at the white letters, it can mean any of those things to a person when they hear that word. When you look at the gold letter, or the yellow letters, we're talking about it as a human in a research study as opposed to a mouse or a rat, right? The problem is patients hear that word and they hear it in many different ways. It's both a noun and a verb, and we use it that way. Now that may not sound like a lot, but think about that for a minute. Are you a subject who's going to be subjected to research? That's the connotation that we give to people. So I think we really have to get rid of that word. It's more than a semantic issue. It's more than a feel-good issue. It's actually hurting the way we project clinical research in our country. Now there's consent. What does that mean to people? We have a form that complies with federal regs, right? That's what we've been talking about almost the whole day. Thank goodness we've been talking about more than just a form in some cases. Okay, what does it mean to people? Well, it means that I sign this to get my medical care, or it's what they're going to do to me, and then I sign it. Okay. So again, thinking about these concepts from the patient-centric or the patient-focused side of things, we have come up through the years, many discussions, some of you have built your entire careers on these Band-Aids that we've been putting together. And I don't mean to insult you, I really don't. There are a lot of really dedicated, conscientious people who are trying hard to make this system work. But the fact is, we're putting Band-Aids on a patient who's bleeding out. The system isn't worth it anymore. We've got to come up with new ways of doing this. And there's a list of things I'm not going to go through at this point, but you know, there are many things that we've discussed over and over. We need some fundamental change. So it's time to get real. And I mentioned this earlier, but the research system, in looking at this, really does seem to be regulatory focused. There are reasons for that I'll go into, not patient focused or patient centric. We have to stop saying that informed consents are for patients and then create them for the institutions that are managing risk. That's just not going to work. It doesn't work now. It's not going to work in the future. Patients, what you need to understand is when they're looking at this, when they're considering research, they're thinking of their own care, and they don't want the pill or the treatment or intervention that's listed on that clinical trial that we're spending hours talking about. They want what could be the potential result from that. Now, they need to know, and I please understand, I am not saying we don't need research protections. We absolutely do. There are major atrocities that have happened, and unfortunately, some of them are fresh in our memories as well. So we have to protect people. But we have to protect people in a way that they're going to be able to understand and process the information so that they can make a decision that's right for them. So it is time to restart your computers in case any of you have Windows. You've seen this screen before. And it's now time to not just reboot, but actually restart the computers. One question that actually came up, and it came up pretty prevalently in our discussions today, is why do we have this artificial separation in the way that we talk about research versus care? Obviously, we need additional protections for research, but the fact is the research regulations the regulatory focused system, has been created by penal policy, I have to be careful how I say that, and which has been focused on reactions to bad things happening to people, right? But really, that's where we've come up with our regulations. It hasn't been proactive. It hasn't been strategic because we wanted to put together a whole research program that made sense. It's been reactive. So, and the concerns are definitely valid. But what has happened is it's created a fearful environment. And so everybody focuses on that because you don't want to get caught, or you don't want to get your hand slapped, or you don't want to get shut down. But on the other end, people want individual results. We talked about that a little bit today. They want them in a way that they can understand them. They want data shared, but the regulations we have actually thwart that process. And I've been involved in a lot of data sharing discussions as well. So really the question is, what is it that we're trying to accomplish here? Are we focused on the peg, and does it have to be square? Or are we focused on the hole and it's round, and so how are we going to make these things work? What is it we're really trying to accomplish? I think we have to step back and decide what kind of a system do we really want to have? Not what we've got today, necessarily. Hopefully we would not create a system today that would look like what we've got. So then we get to the C words, and I don't mean cancer. I mean useful communication. That's really what we're talking about. And we've used the word education, but frankly, communication is what we're talking about there. Communication skills are what we need with our healthcare professionals who are talking to people about clinical trials. And we have, the word that has not come up at all today is context. We have to have context for whoever it is that's involved in this process. When it's a patient that is a potential trial participant, then we need a context for them so they can understand the information we're telling them in a way that makes sense for them to process. If we're talking about the research associate who's trying to get the consent from the patient, then we need to talk about their context. We need to talk about the context for the investigator, for the statistician, for the nurse, everybody involved in the process. So how do we do that? Well, that means we have to change the culture. Okay, now some of you have said, oh, but isn't that hard to do? Yeah, it is, but it can be done. And with projects and pilots like Sharon's talking about, that can be a possibility. So I think one of the things that I learned today was that I think there are parallel actions that we have to take. We can't just let regulations, changing regulations do it. That by itself isn't going to change the culture. We can't just say, oh, let's try these educational things and get some more skills training for people. That's an important step, but it can't do it by itself either. It's not an either-or proposition. We've got to come up with a whole program, a whole plan that takes both of those things and probably some more things I'm not thinking about into consideration. And to focus on where we want to go, not where we've been and what regulations we have to adhere to today with the way that we've always done things. Because frankly, the world is passing us by. So if we focus on that, you just become bigger dinosaurs. Patients want a path that's going to fit themselves. This question I don't have time to go through right now, but if you want to in the panel discussion, we could. What really is therapeutic misconception? Because from a patient standpoint, if you're talking to them about some kind of treatment or intervention for a medical condition that they have, that is their treatment. So I understand, believe me, I've had many debates with some of you in this room about that term, but we have to rethink what does that really mean and how do we get the information we need to get across to the patients in the context that they can understand. IRB and consistency, we've talked about a little bit about that today, but not very much. The fact is people don't have equal access across the country based on what their IRBs allow. How is that ethical? If we live in a big country like we do, how is it ethical for somebody in Nebraska not to be able to have the same thing that's available to them in Houston? That's something we really need to think about. So therefore, the local issue of IRBs may be something that we really need to address and take a look at. This point is one that we haven't really made today either. patients, absolutely, I'm starting to have more and more conversations with people, want to re-identify themselves. So we talk about all this de-identification stuff. That's great for discovery research. But when the new molecular signatures come out, they're going to want to be able to go back and use their sample or their data to find out if they've got that molecular signature. So that's something we haven't even discussed today, but it's something that needs to be in the mix. So I think we have to change the approach. If it's okay, we need to separate these concepts, first of all, okay? There are at least two different motivations going on here in clinical research that you guys have to try to balance every day. One of them is things from an institutional and an industry standpoint. And it's okay to put in risk management if we need to, but please don't pretend that that's to the patient's benefit. And it has to be separate from informed consent if we use that same term. But whatever story we're trying to tell about the study we want them to consider needs to be separate from the risk management of the institution. I think we have to step back also and say, do we really need all of these pieces that we have associated with this regulatory focused system? I mean, what we do is we say, oops, that's not quite good enough because we reacted to this latest horror story. So let's add another agency in here, or let's add another whole process or a whole nother regulatory piece to this. We keep adding to the whole thing. We need to step back and say, if we are building a coherent system, how does this really need to work? And it's okay not to have everybody involved in that. If we have key people involved who are going to be accountable for the results that come from it. And then you heard what I had to say about subjects, so this is just another part of it. But remember, you don't partner with your subjects. There's a reason there's a crown up there. Okay. We have to change the approach again. It's not 1974. It's not 1991. These were phones that changed because they didn't have a cord on them in 1974. It changed in 91 because it was much smaller, compact, and could move with us in a better ways, and didn't have just a 20-minute battery life like the one in 74. Today, this is actually curved like that, and we have much more than just a phone that we use every day in our hands. So that's what I'm talking about, thinking about where the world is today, not where we've been. Okay. So in 2014, lots of things available to people. Again, I won't go through this. At one point here, you're online forever, right? Facebook is having all sorts of debates and issues about people who die. What do we do with that Facebook account? Okay. There's a Kickstarter company that's trying to get started that's going to create perpetual, basically, it's not lifelong, it's way beyond your own life, avatars, so that you can actually your avatar can interact with your great-grandchildren. Now that, I'm not going to go into the details of that, but it's really kind of, you know, you need to think about those kinds of things. Okay. So what if there were no IRBs tomorrow? What would that mean? Now, you know, I'm sure a lot of you are thinking, what the heck, get her off the stage. What is she talking about? But the fact is, I talked about the conflicting committees. If we were building a new system today, these are the kinds of things I would hope we would be discussing. How would we handle uncertainty? Because that's really the big issue that we're talking about. The risk, the uncertainty of what's going to work, what isn't going to work. Accountability, who's going to be accountable for some of this stuff? That word didn't even come up today. Transparency did, health literacy did. But let me explain something from a patient standpoint. Health literacy doesn't mean that people are really anxious to learn this new thing. I don't know anybody that you talk to who's a patient that says, oh yeah, I'm excited about becoming health literate. They want to know what they need to know. They want the information they need to make their decisions. They don't want to have to learn a whole new field themselves. So we have to think about it that way too. Okay, Laura brought up this a little bit. The fact is, there are examples that we should be looking at right now of things that went well and things that did not go well, and how can we avoid that as we start to build the strategies that we need to develop a system that actually works for people and for researchers and for even regulators and policymakers. You know, the universal research consent, someone brought that up, the simple or the broad consent. It's not a new idea. It's been around for a long time. I have no idea if this is going to work or not, but there's some things that we should probably discuss about it and see what makes sense. And what if there was a consent app? You know, everybody's got their phone now. So what if that was there? Reconsenting. Everybody has their permanent cell phone number. You know, why is that such a big problem in the world that we're moving into, not the world we've come from? So last, if you want to stay in the box that we're in, these are points that I think are important. So if we stay with the same system and continue to try to tweak it, then we have to remember these things. Okay? Partnership, respect, and trust are critical. We need to build multiple models like Sharon was talking about, evaluate those and learn from them and try to build from there. We need feedback loops on everything. We certainly have that available today. We need to use that technology and constantly adapt. I just bring this up as an example. We've already talked about this kind of stuff, but this was a really interesting article in the New York Times. I don't know if anybody read it or not. This girl, who is a journalist, went through and got her DNA tested in 3 different programs because she wanted to see what results she would get. They were all different. This is the kind of dilemma, actually, that patients are in every day. Now, this is not having to do with research necessarily, but it's a situation that we've talked about today, and it's only going to get worse. And there isn't much value that can be gotten from 3 different kind of test results. So these are the kinds of things that we need to try to deal with now so that we prevent problems in the future. Thanks.